Hello, everybody, and welcome to this webinar about the use of disposable bronchoscopes. First of all, let me introduce myself. My name is Stefano Gasparini, and I am a professor of respiratory medicine at the Polytechnic University of Marche region in Ancona. Ancona is located in the middle of Italy, on the Adriatic coast, just in front of Croatia. I work in the respiratory disease unit of the University Hospital of Ancona. I was chair of the interventional pulmonology group of the European Respiratory Society. I was president of the Italian Association of Pulmonologists, and I'm currently vice chair of the World Association for Bronchology and Interventional Pulmonology. It is a great pleasure for me to chair this lecture and to introduce Dr. Marcus Kennedy. Dr. Kennedy is a pulmonologist that works in Cork University Hospital in Ireland. He is a friend, very active in the field of interventional pulmonology, in the European Association for Bronchology and Interventional Pulmonology, and also in the World Association for Bronchology and Interventional Pulmonology. His main area of interest and research is the development of diagnostic and therapeutic devices for bronchoscopy, and he is involved in projects on the development of new magnetic navigation platforms for bronchoscopy. The topic of his lecture is of great interest, especially in this moment of SARS-CoV-2 pandemic. He will talk about the single-use flexible bronchoscopy. You know that one of the major risks in bronchoscopy is the risk of cross-infections transmitted by the endoscopes, and the recent advent on the market of disposable bronchoscope may be a great advantage to avoid the problem of contamination and the risk of infection. Reprocessing for flexible bronchoscope is a complex procedure, and it requires competence and great care, and it may be difficult in many situations, like bronchoscopy at night or in emergency room. So disposable bronchoscopes may be an essential tool, not only in the COVID era, but they will be of great value even in the future, since the frequency of multi-resistant microorganisms is growing, and it will be a great problem in the future. Dr. Kennedy will illustrate the possible advantages of using disposable bronchoscopes, both in the pandemic era as well as in the future. We hope soon, when SARS-CoV-2 will be over. Please, Dr. Kennedy.
Thank you very much for the introduction, Professor Gasparini. It's an honor to share a podium with you. So I'm going to open up my and share my screen now, and I hope you can see this now. Can you? Yeah, so you can see that. Okay, so, and I would like to thank the surgical company for organizing this webinar. So the title of my talk is Single-Use Flexible Bronchoscopy, Technology for a Modern COVID and Post-COVID World. So the topics we'll cover include cleaning bronchoscopes, the risk of infection from bronchoscopes, risk of infection in the COVID era, types of single-use flexible bronchoscopes, advantages and indications, evidence of efficacy, cost, cases, and our experience at Cork University Hospital. The main question is, are single-use bronchoscopes ready for prime time? So I would also mention, as Professor Gasparini mentioned, and he is the Vice President of the World Association of Bronchoscopy. I chair the literature review library there, and there's plenty of papers and summaries that are free to look at, and it's a great website and resource of information. That's the academic library, but overall the lecture library, the image library are all very good training materials. So our group has published a few papers on single-use bronchoscopes, and I'll be taking a lot of this talk from there. So when we think about prime time, when we look at prime time TV, prime time TV needs to be a good concept, better than before, not a rerun, exciting and generate a lot of press. There has to be audience comfort and wide applicability in that it needs to be safe and not a wild card. There has to be room to grow, good writers and actors, and a loyal and local support. Of course, with primetime TV, you're dealing with the public's fickle taste, and something that's primetime today will be obsolete and on reruns tomorrow. So a primetime procedure, it also has to be a good concept, better than before, not a rerun, exciting and generate a lot of press. And I would state that single-use bronchoscopes fit this description. There has to be audience comfort and wide applicability. There has to be room to grow. It has to have good writers and actors, in that it has to have good companies making the devices. There has to be a loyal network to use the devices, and we don't really deal with the public's fickle taste as regards procedures. So first of all, we talk about reprocessing of reusable flexible bronchoscopes. And reprocessing medical equipment comes under the Spalding classification. And that includes non-critical, semi-critical and critical devices. So bronchoscopes fit in the critical area, and they need to be cleaned properly or single use. So scope cleaning, we don't sterilize scopes completely. So what we do is there's a pre-cleaning phase. We do a leak test to make sure that the interior of the scope is not damaged. Then it's cleaned, and as you know, it's cleaned manually. Oftentimes in the bronchoscopy unit, a cleaning agent is suctioned through the scope, and it can be cleaned in an automated process as well. So we rinse the scope, then disinfection is used, and that can be in an automated endoscopic reprocessor or manually. It's rinsed again, and then finally they need to be stored in a clean environment. And there needs to be a drying area and adequate storage. It's recommended they're not stored with GI endoscopes, obviously. So there's a lot of steps here, and this can go wrong. And also there's a lot of exposure to, for instance, COVID infection to the folks who are cleaning the scopes, if a scope is contaminated with COVID. So they should be stored, as we said, separately, and PPE is required for this process, regardless of COVID. So why are scopes not sterilized or autoclaved? Well, chemicals are used for sterilization, and they're expensive, and they would actually damage a bronchoscope. And scopes are not suitable for autoclaving. So high-level disinfection is what's used. That eliminates bacteria, viruses, and fungi. But bacterial spores are resistant, as are the spongiform encephalopathies, such as mad cow disease as such. And it depends on adherence to protocols. So the ECRI were originally founded as the Emergency Care Research Institute. It's an independent, non-profit organization improving the safety, quality and cost effectiveness of care across all healthcare settings worldwide. In 2019, they highlighted contamination of flexible endoscopes due to mishandling and improper storage as one of the top 10 health technology hazards. And they refer particularly to recontamination of disinfected endoscopes caused by failure of staff to change their gloves between inserting and removing the endoscope from the AER. Now, this is a paper. We'll be talking about this paper a little bit more in time, but it includes 16 studies identified for quantitative analysis of the cross-contamination infection risk of bronchoscopes. So all these papers highlight infections related to bronchoscopes, and overall it suggested that there's a 2.8% risk of infection with a bronchoscope. Now, of course, bronchoscopes go through the patient's mouth, okay, and that's not clean. So you may be, placing a sterile scope into the patient. However, it does go through the mouth, and you are picking up organisms from there. This was an editorial by two world leaders in bronchoscopy, Atul Mehta and Thomas Gilday from the Cleveland Clinic. And the title is "Burying Our Heads in the Sand: Cross-Contamination During Bronchoscopy." And this was an editorial related to this paper, which was published in Chest in 2017. The effectiveness of reprocessing for flexible bronchoscopes and endobronchial ultrasound bronchoscopes. So in this study based in New York, in 3 tertiary referral centres, including 2 transplant centres, researchers assessed 24 bronchoscopy procedures, including EVO scopes. This included observation of cleaning of the scopes, of the high-level disinfection equipment and policy, inspection for scope damage. So what they actually did here was put small little borescopes inside the bronchoscopes and looked for damage and took samples. So a small little scope in a scope. And they looked at contamination post-cleaning using culture and tests for protein, hemoglobin, and DNA. Reprocessing practice and storage cabinet cleanliness was evaluated before inspection and ATP tests. So the results were profound. So in these 3 academic centres, all scopes had residual contamination, human DNA and protein. And I wonder if you consented your patient for bronchoscopy with a reusable bronchoscope and said that there was nearly 100% chance that someone else's human DNA and protein was in that scope, what would they say? There was microbial growth in 55%, including bacteria that would cause disease, Stenotrophomonas, E. coli, Shigella, and mold. Now, just because you grow it in 55% clearly doesn't mean you're going to get, an infection. However, again, if you told your patient that over half the time we would grow a bug that could cause severe sepsis, they wouldn't be too happy. All scopes had other visible irregularities, including trauma. Reprocessing practice were substandard in 2 of the centres, and these are academic centres, including transplant. So it's unclear at this point what the contribution of these findings to post-procedure infection is. However, regardless of the lack of this information, these findings are concerning. Mycobacterial isolates, viral cultures, and genomic analysis undoubtedly identify further contamination. Even standard cleaning practices recommended by the manufacturers and your regional governance bodies may be inadequate, and consideration needs to be given to the sterilisation of bronchoscopes or cheaper disposable scopes. The reduction in size of bronchoscopes and new devices for peripheral lesions may further complicate cleaning. Prospective trials correlating contamination with infection are required. So here's some images. So this is residual debris on patient-ready bronchoscopes. So this is the white residue under the rotary control ring of a bronchoscope, and you can see an EVO scope with a crack here, which grew infection. This is the inside of a new bronchoscope. However, these were the insides of patient-ready bronchoscopes with dents, with fluid, and filamentous debris. And here is a new bronchoscope compared with a patient-ready bronchoscope with white, brown, rusty discoloration. Arrows point to the same location in these channels. This was the overview of the adherence to current endoscopic reprocessing guidelines in each centre. One centre nearly complied totally, the other 2 completely were not sticking to a standard cleaning processing. So this is obviously a huge issue. Of course, the guidelines for safe bronchoscopy, so I chaired this is the Irish guideline for COVID. Of course, this clearly brings into a view issues with cleaning bronchoscopes. So it's under the microscope even more now. And is there a risk of spreading COVID with a contaminated scope? Well, bronchoscopy in general is an aerosol generating procedure with transmission during the procedure to healthcare workers. So we know this. The transmission of viral respiratory pathogens via reusable bronchoscopes has not been reported. So that's patient to patient spread. However, the potential of this it has been reported by the same author of the prior paper. This is the potential impact of contaminated bronchoscopes on novel COVID-19 patients. And they state that the reprocessing effectiveness has not been evaluated in epidemic settings, and research is needed to confirm that COVID-19, influenza, and other pathogens are eliminated in these settings. The use of sterile and disposable bronchoscopes would reduce the risk for patients and reprocessing personnel, and this approach has been recommended by the AABIP, amongst other bodies. Okay, so these are from our review paper. These are the current available single-use bronchoscopes. So VATIN Medical has a number of different scopes of different diameters available. Access Vision and the surgical company, they had an older scope which has been replaced now by the Agile and Vortex scopes. And Ambu, have a number of scopes available, and these would have been traditionally used in the ICU. However, they've been developed to be used now in the bronchoscopy suite. Boston Scientific and I believe Pentax. I was at the launch of the Pentax scope at the ERS in Madrid in 2019, but it hasn't really come to fruition as yet. But I believe they're both going to launch scopes at some point. So looking at clinical scenarios where single-use bronchoscopes have advantages. So bronchoscopy in the ICU, Professor Gasparini mentioned this, that ease of mobility allows you to bronch easily in the ICU. Bronchoscopy in the emergency department or even the ward. Now, it's important if you're going to scope in the ward that you have adequate staff. You may want to consider bringing your endoscopy nurse to the ward. Don't be in a situation just because it's handy to do the scope there. It's not a bronchoscopy suite and you've got to be careful. So emergency bronchoscopy outside the healthcare facility is feasible. So practicality, these scopes allow out of hours bronchoscopy. You don't have to have someone around to clean the scope or fetch the scope for you. End of day lists where staff are not required to stay and clean scopes. So this is important if your staff are waiting to clean a scope and they're getting paid overtime. You could use single-use scopes at the end of the list. We actually keep a kit now with our BAL equipment and a single-use scope ready to go. Weekend bronchoscopy now is feasible where staff are not available to clean scopes, and bronchoscopy is available for airway inspection with EBUS procedures. So for instance, in our centre, up until now, I didn't have enough bronchoscopes to do a standard airway inspection on every EBUS patient, which is what's recommended. However, now I use a single-use bronchoscope on all these EBUS procedures. We should be doing a standard airway inspection, which is not feasible with standard EBUS scopes. So specific scenarios where reduced risk of cross-infection is critical. So, one would consider the immunocompromised patient, but also scoping someone with prion disease. As you know, if you do, you have to destroy the scope afterwards if they've proven to have prion disease. So other applications, bronchoscopy training, I'll talk about this. Veterinary procedures, I've given my vet a single-use bronchoscope, and large animal or cadaveric research. It's very costly to get bronchoscopes in for research and transport. For myself, we have old bronchoscopes and processors. However, single-use bronchoscopes are going to revolutionize, I think, research in bronchoscopy. So looking at the evidence of efficacy of single-use flexible bronchoscopes, to hear some of the papers, sorry. So they've been looked at in elective surgery. So the comparison was Ambu. The intervention was intubated patients, orotracheal intubation in anesthetized patients, 60 patients randomized to either group, and there was no difference in the global rating scale in these two groups. So this was intubation using a standard bronchoscope or a single-use scope. ENT surgery, Ambu versus conventional video scope, tracheal intubation in awake patients, just a 20-patient study, and the scopes were clinically acceptable. There was 2 instances of blurred image after lignocaine injection, or lignocaine where lignocaine was given in the airway. So Ambu versus conventional bronchoscope for sample collection. This was a BAL, and they reported greater sample volumes in the single-use scope. However, this was a small study. So these are the evidence of efficacy. Another paper that was recently from 21 Spanish pulmonology services using the ambuscope. They used the ambuscope in 300 procedures, and there was no comparison here. They did look at learning curves, which were evaluated by CUSUM analysis. And there was 300 procedures, bronchial aspiration 69%, and what they call the aspiration quality, so the ability to get an aspirated sample was 80% of the time. They were happy. And they highlighted portability of the scope. So just looking at the procedures that they did in this study, mostly lavage. There was also some biopsies, and the route of bronchoscopy was here. So in general, they were happy with the procedure. This is from one of my old alma maters at Duke University when I was a resident. Moman was a fellow and Scott Schofer was a resident with me. So what they did in this paper was they designed a survey to evaluate the performance of the Vatin bronchoscope in comparison with the bronchoscopist standard bronchoscope, or if they were using a single-use scope already. The operators ranked the scopes as regards handling, maneuverability, and tool interaction in a simulated setting. And overall, this was the demographics. So there was attendings and fellows, the number of bronchoscopies that they did. So, and this was the scopes that they were already using. And in general, the reports were that reusable provided better maneuverability in 53%, better suction in 57%, ease of use and better image quality. So people were in general happy with the reusable, sorry, the single scope. So the reusable scope was better. However, they stated, I suppose, 47% of the time that they preferred the single-use scope. So there was, the outcomes here were, 50-50 essentially across the board. Another paper that came out recently in 2021, this was safe and efficient practice of bronchoscopic sampling for mechanically ventilated patients, a structured evaluation of the new Ambu Broncho Sampler system. So I've seen this system. So it's a kind of a dedicated BAL system. This was from Dr. Singh and Palav Shah from Brompton. And this is the device that Ambu have come out with as opposed to standard BAL. And in general, the findings here I would comment on. So bronchoscopic sampling should be safe and effective. Current sampling practice risks loss of sample to the attached negative flow, aerosolization or spillage due to repeated circuit breaks. Now, personally, I don't have this issue when I'm taking a BAL, so I don't think the background here is relevant for a lot of people. However, what they did was an observation of 20 sequential bronchoscopes using this newer device. And in general, they found that the mean specimen yield was good compared to standard sampling. They said the setup was easier, and it was much more intuitive than a standard BAL. Now, I don't have issues with a standard BAL myself. I've seen this device. I found it a little bit finicky personally. I've played around with it, and maybe if I use it clinically, I may have a different opinion. So, they were arguing that if you have issues with BAL, this sampler might be easier to use. And of course, it's a closed system, I guess, for COVID. However, I think standard BAL, if you do it properly, there shouldn't be issues. So this is just looking at cost effectiveness of single-use flexible bronchoscopes. So this was a retrospective study of single-use bronchoscopes versus fiber optic. And they allow for initiation, outlay, storage, and cleaning. And overall, a at a frequency of up to 200 fiber optic bronchoscopes a year, it was more useful to use single-use scopes in this study. Another study looking at cost effectiveness, this was a micro costing analysis for single-use versus reusable scopes. And they incorporated the cost of treating a 2.8% infection risk. So this was the table I showed you earlier on. They assumed no infection risk with single-use bronchoscopes, and they found they were more cost-effective owing to the elimination of infection risk. Another paper looking at cost of reusable versus single for BAL and percutaneous tracheostomy. So they, in general, in this study found that the cost of single-use scopes was comparable. And finally, this is comparison of the environmental impact of Ambu to reusable scope. They use a simplified life cycle assessment with comparison and incineration as disposal method of the single-use scope. They couldn't conclude anything as regards which is the greatest environmental impact, but this is something to consider, of course, with a single-use device. Is the environmental impact. So this I just show you, this is from the TSC company. So this is an app to look at, you know, calculating is it cost effective to convert. So they have purchasing price of the scope, the number of scopes in house, costs of maintenance, which, you know, you have a maintenance contract per year with reusable scopes. Purchasing video processor and light source, purchasing price of other materials, disinfecting equipment, maintenance and storage of the scopes, depreciation over time, hands-on staff time per scope, hourly cost of the staff, maximum storage time of the scope, and yearly purchasing cost of detergent. Other costs are put in here, so you can calculate this out, and you can calculate the estimate cost per procedure using a reusable scope of 236, but when you include cross-contamination, 529 euros. So this app is available, and you can look at it and consider the outcomes, you know, and it depends on how many procedures you do. If you do a lot of procedures, you know, maybe this cost comes down. However, it's something to consider and look at. So to go to the next slide, 1 second now, I'll just escape out of here. And so this is some data from Cork University Hospital, our centre. So this was up until the end of February. I think we had 58 procedures with a new BronchoFlex scope. What we found, so this is just a video of the let me see, will this work here? No, I'll skip the video there. So this is the single-use bronchoscope data that we had. So the indication for the procedure: infection, mostly malignancy, airway disease, abnormal imaging, query COVID in 2 patients. This was the COVID status: negative, suspected, and positive. This was the procedure we did: airway inspection, BEL, washings, brushing, so on and so forth. We did some cryobiopsies, APC, stent patients, placement, electric cautery. This was the location, mostly the endoscopy unit, however, highlighting it could be done in the ward, in the ICU, and theatre. And this was the type of scope. So initially we're using the older BronchoFlex scope, but we converted to their newer Vortex scope, which is a nice scope, a 2.8 channel. And the Agile is a smaller scope, which is more ideal to go to the periphery. And this was the complication rate. So in general, there was no complication in 81%. In 19% there was, but that's a low amount, as you can see. Issues with suction, I'm going to show that in a minute. Issues with image. Most of the complaint is the screen is small. So a lot of the companies have, obviously, there's a screen supplied, and that's to overcome a CE mark. You need to have a medical standard screen, you know, with these scopes. You can't be plugging them into a laptop as such, you know, because it's very hard, obviously, to keep a laptop clean. So the issue with the image was one of my colleagues, you know, who's visually impaired, who says the screen is too small. However, the newer BronchoFlex scope will have compatibility to with a screen to link into your own endoscopy system. And I believe some of the other companies have this already. A cable break, this occurred when we were removing a stent. In general, the newer scope, there was less complications and more satisfaction. This is just we published this. This is what the scope looks like. And this is just doing a TBNA, identifying small cell lung cancer. This is a video of just a standard airway inspection, just shows you the nice image with the scope, which you can see. So it gives you a more than adequate image, I think, for inspection. This is just a bronchoscopy brushing with the single-use bronchoscope. So you do have a nice setup where you can get videos and images easily. This is just an endobronchial biopsy of a tumor, as you can see. This is a cryobiopsy, so Professor Gasparini is an expert in this. He's probably going to laugh at my biopsy here, but this is an endobronchial cryobiopsy in a patient with a history of a carcinoid tumor, which had close margins. So we're able to take a cryo with this. This is argon plasma of an upper lobe tumor, so APC or argon plasma coagulation with the single-use scope. And finally, this is a patient who had a stent, who had an esophageal cancer, and you can see the other esophageal stent just in the corner here. So this is the esophageal stent eroding through the left main bronchus, and we're just moving the stent here with the single-use scope. And this is where we had a snap in the cable. Now you can have a cable snap in a standard scope as well, you know, but you know, the single use in this one, the one of the cables driving the scope snapped, but this can happen. We would say that the older Axis Vision scope, some of you guys might still have this one. There is a small label here stating don't turn the suction up above 400 millimeters because the actual suction chamber can collapse. However, the new one, it doesn't do that. Now, for the BronchoFlex scope, the suction goes straight through the scope, so the suction connector is superior. That can create a loop. The loop can kind of collapse here, so you got to be careful for that. So this is my current register, and she's showing us how to hold the suction coming out of the BAL here, and this is just a video of that, where she's holding a loop here to prevent this collapsing. Okay, so just be aware of that. So overall, our user satisfaction was excellent. 90% of the time, we were very happy. Training. So this is unpublished data using the single-use bronchoscope. This is my low-fidelity simulator with rolls of toilet paper and Play-Doh. Play-Doh is great because you can cauterize Play-Doh. It carries energy. And this is training some residents in bronchoscopy. We were using a modified standard score, the B-stat score. And this is what we did. We have 14 residents and 4 fellows, single-use bronchoscope, and our ALFI, which is our airway low fidelity, including EBUS simulator, and residents and fellows were looked at. I must say that the surgical company, or TSC, donated a screen and 10 scopes for training, which is fantastic. What we were able to show was significant improvement in residents and in general. Now, fellows, it wasn't significant. However, there's only 4 fellows. And overall, there was a significant improvement in training. This was just with a short simulation training using a single-use bronchoscope in brushes, in biopsy, and in scope handling. And also this differentiates the resident from the fellow. So a resident pre-training and a fellow pre-training, there was a difference, and residents and fellows post-training. So this is just some videos. This is just training them in how to do a brushing. And then you can see here they're doing the brush. So this is a tumor mimic using Play-Doh, and you can see them just going ahead and brushing there. I find if you leave the Play-Doh out for a few hours, so Play-Doh is, as you know, it's a modeling clay for kids. It's called Play-Doh, I guess, is one of the international brands. And this again is some residents doing a biopsy using our simulator, and again you can see the biopsy here using the single-use Axis Vision bronchoscope. So great for training. Interesting area that I'm interested in now is using these scopes for other applications. This is off-label, but this was a study from, again, in England, Newcastle, a novel technique for laparoscopic common bile duct exploration using a single-use bronchoscope, looking into the bile duct at stones and at the junction in the common bile duct. So there are other potential applications. So in summary, bronchoscopy in the ICU, yes, bronchoscopy in the emergency department and outside the healthcare facility. Out of hours bronchoscopy, end of day lists, weekend bronchoscopy, and a scope available for EBUS are all advantages of single-use scopes. The immunocompromised patient, the prion disease patient, single-use scope, potentially the COVID patient as well, obviously, because of reduced risk of staff associated with infection and potentially patient associated infection. But again, there hasn't been a patient-to-patient transfer. You would think that it's possible though. Other applications: bronchoscopy training, veterinary procedures, large animal cadaveric research. So finally, is it a good concept? Yes, I think so. Audience comfort, yes. These scopes are easy to use. They're lighter, actually. And one of my trainees said her hand is smaller and she finds it harder to use a reusable scope, given the distance from her thumb to where she grips the scope. However, the single-use scopes are lighter and easier to use. There's room to grow. Good writers and actors, good companies making them. There is a large loyal network, and we don't have to deal with the public's fickle taste, thank God. So I think they are ready for prime time. So I'd like to thank a few people, the surgical company for putting on this webinar and for supplying me with scopes for training, my residents and fellows who were helping me research, and Irish Hospital Supplies is the supplier in Ireland. So thank you.
I thank you very much, Dr. Kennedy, for your excellent presentation. You underlined the multiple advantages of single-use bronchoscopes and the different situation where this instrument may be useful. And I would like to say sometimes necessary. For the reason that you described, I think that the single-use bronchoscopes will play in the future an ever-increasing role in the bronchoscopic activity of every interventional pulmonology service. So thank you again. I enjoyed it, your lecture very much. I have some questions that I would like to do to you. The first one, you showed the advantages of using disposable bronchoscope, even in terms of cost. This is one of the major issues for people to use a single-use bronchoscope. Could you spend some more words to give us some more details on the economic impact in terms of cost of the single-use bronchoscope?
Yes, so I guess the comparison obviously is to reusable scopes, and the app that I showed and the website is available through the surgical company, and that gives a good cost comparison. When you're looking at cost, you have to consider not only the outlay initially of a reusable scope, but also obviously your processor, your ongoing contract to service the scope damage, the cleaning of the scopes, all the agents required to clean them, the storage of the scopes. I mean, you guys like me probably have reduced space for bronchoscopy and storage, the storage of the automated endoscopic reprocessor, the staff that cleans the scope. So when you take all those factors into account, you know, you will find that a reusable scope will more than likely be cheaper than a single-use scope would be more than likely cheaper, especially if you're doing a lot of procedures. If you're only doing 50 or 100 procedures a year, obviously then you know, maybe that the reusable scope is more cost effective. But if you're doing 50 to 100, the single-use scope is more cost effective. If you're doing between 1,000 and 2,000 procedures a year, maybe the cost ratio pushes towards the disposable scope. However, I would say that if you went to your patient and you said that, if you were consenting your patient and said that I'm going to put a scope into you that maybe 100% of the time has other person's protein and DNA, and 50% of the time have an infection, you know, I don't think there's an argument there in a lot of patients to continue with the reusable scopes.
Thank you. And we use a single-use bronchoscope, and in our experience, one of the advantages is the possibility to perform bronchoscopy at the bed of the patient without moving all the instrumentation required by the traditional bronchoscopy, like source, and this changed our life because we are ready to run at the bed of the patient in any moment without any problem, and just bringing the single-use scope with us. So this is a very easy and very practical issue. And especially in this time of COVID, we are called a lot of time during the day or during the night to perform bronchoscopy or bronchoalveolar lavage for diagnosis, for instance, in patient with negative swabs, or to clean secretion or clothes in IC units. So we use a lot of time single-use bronchoscope, but in these cases, we need to protect the screen of the scope by contamination. If we are going to a bed of a patient with COVID-19, what is your suggestion to protect the screen and to cover the screen if you perform bronchoscopy at the bed of an infected patient?
So I would say again, you know, if you're going to the ward, make sure you know what you're doing, because you might not have your endoscopy nurse with you. So an expert like Professor Gasparini knows what he's doing, knows how to handle the scope, you know, and knows how to do a BAL. However, just remember, you know, be aware that you don't have your endoscopy nurse with you, and if issues arise, you know, you need to be ready. So the cleaning of the screen, obviously the screens are there because we don't want to be bringing up, you know, our own screens and, you know, laptops. I mean, at the end of the day, these scopes have a small HDMI connector that one could plug into a laptop. However, the screens that are supplied are easily cleaned, you know, so they are easy to clean, similar to an ultrasound screen. So we just wipe down the screen in general before and after, but you have to be aware to do that, right? You know, you can't just wheel in the screen and not clean it. So you got to wipe it down with a disinfectant and be careful. I believe Professor Gasparini, you know, are some centers using a cover for the screen? What's your experience there with that?
Yes, we are using a transparent paper sheet.
Okay.
That we envelop the screen with this sheet that protect from infection. It's easier, and in any case, we clean and we disinfect the screen after the procedure.
Yes.
But yeah, we do the procedure with a screen protected by a transparent sheet. Perfect. That is very easy and very cheap to have.
Okay, very good. Yeah.
And another very interesting point or your talk was you showed the suction capability of this single-use scope. Could you spend some more word about the suction capability of these scopes?
Yes, so you know, we use the 2.8 channel scope traditionally. I guess Professor Gasparini, that's probably your go-to scope as well as an interventional pulmonologist. We prefer bigger scopes. So with a 2.8 channel, I think there's no problem with suction. Even the 2.1. Now the 2.1, the original BronchoFlex scope, there was an issue if you turned up the suction too high, that the actual channel could collapse. However, the newer scope, that's not an issue. You got to be aware with whatever scope, you got to look and see that the suctioning tubing doesn't kink. With the BronchoFlex, you got to create that loop that I showed you that will prevent it. The Vatin scope and the Ambu scope, which are the other two commercially available, the suction connector goes out laterally, not superior. So that loop is not such an issue. However, the BronchoFlex makers have the straight through suction because they state that it's a better suction. Now, I personally have had no issues with suction. You know, I get an adequate bronchoalveolar lavage. You know, I'm thinking of doing a comparison of suction with the scopes. However, in general, I get an adequate BAL. Ambu obviously are bringing out this new device out with a dedicated suction chamber. I guess that's to reduce, handling in COVID. However, again, the 2.8 scope, my experience, no issues with suction. Yeah.
Thank you. Thank you. It is also my experience. It's the same. And my last question is about the future. Do you think that in the future the indications of single-use bronchoscope will increase, and even at the end of COVID pandemic era?
I think so, yes. I think they've gained traction because of COVID, and lots of us are getting these in the bronchoscopy unit now. Before COVID, it was really only the anesthesiologists and the ICU doctors that were getting these in for, intubation, However, because of COVID, I think pulmonologists like you and me are using these a lot more, and we're just seeing that they're so handy and so efficacious. I think with the development of the connectivity for your large monitors, that'll be a big win, because I do find that when like you, Professor Gasparini, probably, I like to walk around the patient. If I'm going down the left lung, I like to be at the right shoulder. If I'm going down the right lung, I'd like to be at the left shoulder. I was trained on that in MD Anderson in Houston. So you need two screens when you're doing that. If you're at the left shoulder, you're looking at a screen on the right. If you're the right shoulder, you're looking at a screen on the left. And I end up wheeling the single-use screen around behind me with the scope in. So I think the connectivity will be a huge issue when you're able to connect it into your two screens, one on the right, one on the left, for standard bronchoscopy. That'll be a big issue. I would love to see a scope coming out with a capability or a connector to go into a laptop solely for training. That'd be a great step, I think. If you're training, that would allow the possibility of remote training. You could post out a scope to your trainee and have a home simulator and train them at a distance. So I think that'd be huge. I think the European Space Agency and NASA will probably have these scopes in their manned missions. I know they have an endoscope, I believe. I believe somebody has done endoscopy on the space station, but I wonder will they have single-use bronchoscopes going on the manned European missions. So I think definitely these scopes will progress. It'll be interesting to see if an EBUS scope comes out that's single use. I bet it'll come out in time. We're talking about the cost issues and ultrasound. But my trainees have portable ultrasound machines now, so you could easily connect one of those into a single-use scope. So for me, I'll still use a 3.2 channel for my big airway obstructions. I use a rigid bronchoscopy. However, what's your experience, Professor Gasparini, with the single-use scope and a rigid bronchoscopy? Are there any advantages?
Yes, this is very important point. Another very common indication where we use the single-use scope is when we use the single scope, the flexible scope through the rigid scope, and it happens very frequently. For instance, we are used to perform cryobiopsy, intubating the patient with a rigid scope and performing the cryobiopsy with a flexible scope. And I can tell you that we destroyed several times the flexible bronchoscope, removing the flexible bronchoscope from the rigid, because the tip of the rigid scope can damage the external sheet of the flexible bronchoscope. So in the last time we perform always flexible bronchoscopy through the rigid scope using a single-use bronchoscope, because this is a condition where the flexible bronchoscope is at high risk for damage. So this is another very, very useful indication. Thank you very much, Marcus. I enjoyed very much your talk and this discussion. I think that really in the future, single-use scope should be present for several indications in all the interventional pulmonology service. and probably it will be a standard in the future for, I don't say for all the bronchoscopies, but for a lot of procedures that we are performing and that are at risk for the patient, for the infection, and also for the instrumentation. So thank you very much. I enjoyed this webinar. I learned a lot. As my friend and brother Atul Mehta says at the end of his presentation, I'm still learning, and I learned also in this webinar. I thank you. I thank the surgical company and Vision for the perfect organization of this webinar and for giving us this great opportunity to upgrade our knowledge. Thank you very much, and bye-bye, everybody.